and I'm going to be moderating this. So if you put your questions in the chat, I will be reading those and we'll get responses at the end of the presentation. So our presentation today is on COVID and moral distress. Moral distress, not a new concept necessarily to many folks, and yet the nuances of it, particularly in terms of COVID, are new and really very, very challenging. So we have three terrific people who are going to work with us, speak with us on this. The first, Jackie Glover, who is a professor in the Department of Pediatrics and at the Center for Bioethics and Humanities. She's also the co-medical director of the Ethics Consult Service here at University of Colorado Hospital. Reverend Annie Dondapati-Allen is a staff chaplain and is also one of the leads on the Ethics Consult Service. And Karen Jones, who is a nurse, a clinical nurse ethicist at Children's Hospital Colorado, and is on faculty at the Center for Bioethics and Humanities at CU School of Medicine as well. So I'm going to turn this over to them, and will also want to mention, I will mention it again at the end, that next month we will be having a presentation by Dr. Mark Ernest from our Department of Medicine on health policy. Whatever state of that it is, he's going to catch us up on that next month. So today there will be, the objectives are to define moral distress and really distinguish that from other sources of stress during COVID times that are going on, very familiar to all of us, I think. Identify moral distress strategies to mitigate that, as well as resources for moral distress mitigation. So I will turn this over to our speakers. And again, please put your questions in the chat. Thanks.
Thank you, Julie.
You're welcome.
To be here to talk about moral distress, and in this COVID time, couldn't be better timing. Here's two definitions. One from Dr. Morley, the psychological distress that's experienced in relation to morally challenging situations or events. And the other one from a very interesting slide deck at the Hastings Center, the feeling of being unable to do the right thing or being helpless to avoid doing harm. These are kind of premier definitions, but we have to realize that moral distress is a complex concept, and it has evolved, and it comes with some challenges. It began in the literature as moral distress in 1984 with Andrew Damerton's book, Nursing Practice, The Ethical Issues, talking about constraint only for nurses. It's when you know the right thing to do, but you're constrained as a nurse from the hierarchy and the occupational situations that you can't do the right thing. It has evolved from them, that narrow definition to include moral uncertainty or moral pickles or moral dilemmas, and all healthcare professionals experience moral distress. And a lot of discussion about the psychological and the physical effects of distress. Lots of attention to the moral side, and now lots of attention to the distress side. And increasingly discussions about ethical climate. This day, many people can consider moral distress as something only belonging to me and my body. I'm strange, something that I have wrong that I should do better. And it's only internal constraints that you need to deal with. But increasingly, there's discussions about the external constraints, about systems, and at the unit level, at the bedside, at the unit level, at the hospital level, at the healthcare system level in totality. So, and finally, integrity has taken a front and center position in the discussion of moral distress. I have deeply held value commitments, both personal and professional, and I'm distressed when I feel my integrity is challenged. These definitions and conversations about what moral distress is from a very helpful, interesting article from Dr. Morley in the Nursing Ethics Journal about what is it, and she does a narrative synthesis about what it is and how do you define it in order to be able to research it and to point out the outcomes, the important outcomes. There are more challenges. You may be thinking moral distress, I've heard of moral injury. So moral injury is a term that appears mostly in the physician literature. The same kind of concepts. It conflicts, it's a conflict between your individual beliefs and it has long-term mental health effects. The concept does come from the traumatic stress literature and started with discussions about the battlefield. In early descriptions, potentially injurious events included all the things associated with the battlefield and bearing witness and not being able to take care of it. And so close association to PTSD. And Wendy Dean is a physician who has a website called fixmoralinjury.org. And she really attends to the kind of institutional structures that constrain physicians from being able to be true to their challenges. If you're attending to the external, which is both are important, internal psychological and empowerment of the individual, but it's a good thing to talk about the external environment, the ethical climate. And in the literature, there's support, an evidence-based model for leaders addressing moral distress that comes from the Journal of Nursing Administration. And so support stands for, if you're in a leadership position, see and seek moral distress, understand moral distress, pay attention, and most importantly, assess workplace climate, promote a receptive environment and engage team members, open opportunities for dialogue, reflect, evaluate, and revise, transform negative environments. And so the external is very important in this dialogue around moral distress, or if you prefer, moral injury. I am joining the troops that believe that how about we be more positive and not just concentrate on the negatives of moral distress or moral injury. What's resilience and what does it mean to be resilient in the workplace? And this comes from the great work of friend and colleague Cinda Rushton. Way back in 2006, she used this definition of moral resiliency. I'm sorry. She defined it as the capacity of an individual to sustain or restore their integrity. And that's a good word. In response to complexity, confusion, distress, or setbacks. This is an effort to look to the positive and emphasize empowerment, not just of the individual, but of professions and teams. And in her very influential 2018 book, Moral Resilience, Transforming Moral Suffering in Healthcare, she goes on to say, while the concept resilience has been applied in many different settings, including wars, natural disasters, business, climate change, there's no one unique.
I was listening to her end of the conversation.
Can you please mute? There's no one.
Can somebody please mute?
no definitive unifying concept.
Fine, just document it.
Perfectly fine.
David,
You know,
can
what
you
can you
mute
do?
them?
Can't get these people over their head.
So with
Yeah.
these HRO coaches, there'll be some.
Can you mute them, please? David,
But I have to review that transition consent. It seems
please mute.
where the
Please
patient
mute.
signs for the consent is very close to the refusal.
Hello,
Can
mute,
you see that?
hit mute, hit mute, hit mute.
Sorry.
Thank you very much. It's hard to talk over people. So there's one really not definite unifying, but Cinda points to the ability for an entity, an organism, an individual, a person, or a system to withstand, adapt, recover, or rebound from adversity, stress, trauma, and be buoyant in adversity. And she points out this important feature. Resilience can be understood as both a capacity that can be influenced in a process that unfolds to various forms of adversity. And it's not a fixed state, it's dynamic. And we all need to contribute to the growth of resilience in our environments. So what's the relationship between these concepts of moral distress and stress and trauma? You know better than I, there are many sources of stress and trauma in everyday healthcare. But moral distress and burnout and compassion fatigue, all these sources of stress, psychological, bodily, are important. Moral distress specifically refers to the ethical dimensions and the concerns of navigating ethical practice, being true to your ethical professional and personal ethical professional integrity, responsibilities, and duties. Both attention to the psychological state and the ethical issues are important. And people who do moral distress rounds or mitigation pay attention to both spheres and both tools. And so, as my colleagues like to say, you can't talk about ethics when you're in the state of amygdala hijack. And so there's various ways to attend to the psychological, the trauma, the stress. I'll point you to one resource. This is from the Center for Study of Traumatic Stress at the Uniformed Services University. They talk about the importance of these simple structures and these simple things in your practice. Meeting your basic needs. Don't skip eating, taking breaks, connecting with your colleagues, communicate constructively, getting some communication tools, contact your family, respect differences, stay updated, limit media exposure. That's a particularly hard one for me. Do self-check-ins and honor your service and the service of those around you. It is my privilege to share with you here first, what's particular about COVID. I think the overarching arch of the moral distress is that we're moving from a patient-centered ethical framework to a public health ethical framework. And that kind of triggers a lot of distress around the issues, the ethical issues, around visitation restrictions, patients dying alone, risk to your personal safety and the safety of loved ones with the perceived lack of PPE. The reduction of the provision of healthcare services, either by elective procedures or the staffing ratios. And probably the most difficult is the triage and allocation decisions. Both Annie and Karen will get into this at the hospital further. But I wanted, this is my privilege to share with you a wonderful resource, the Colorado Healthcare Ethics Resource, SHARE. We toyed with another Sunny, but many people don't understand who Sunny and Cher is, and so we're dating ourselves. But Dr. Barbara Statland who is a critical care physician and an ethics committee member and consultant at Denver Health Medical Center, worked with a group of volunteers from all over the state. And Karen and I had the pleasure and privilege of working with her to construct this website. Let me show you some of its features. Well, it worked in practice. Oh, is it here? Oh, it was almost here. Oh. David, can you help? What do I do? David?
Well, I don't know. How about we stop sharing your PowerPoint for a minute and then just go right to the site on your desktop, and we'll come back to the PowerPoint later.
Okay.
Maybe because we have 200 people watching, it's unhappy.
Probably. Can you see? Oh, can you see that?
Not yet. Share screen.
Mhm. Did it work?
Yeah, now I got it.
Yes, Jackie.
Success, thank you. So this is our website. We are all very proud of it. So let me show you around. General information, and we designed it to have first aid most accessible. So the most stressful, the most distressed, most stressed, here's some immediate emergency sites. It proceeds on to a discussion of the stress continuum, a wonderful illustration that is a kind of where am I on this spectrum. It proceeds to stress reduction strategies. This is the most watched video on our site. This is a licensed clinical social worker, Ruby Jo from the Western Slope. Why does this feel like this? Because we're human. Be sure to watch this. And then resiliency resources. And then here's psychological first aid, front and center. And then why does it matter, with a compelling AACN video. And here's moral distress impacts, addressing moral distress with resources, definitions, conceptual definitions and suggestions. It goes on to talk about grief and loss. How does it impact you? Impact of stress, addressing stress and burnout, and how is stress related to trauma, understanding trauma. So that's our website. We are proud of it. Check it out, especially Ruby Jo's video.
Now back to your PowerPoint, and you should be okay.
Am I back?
Not yet. Share screen on your PowerPoint.
Oh, I can't. David, I can't get to the,
Looks like you're not sharing your screen.
yeah, I can't get back to Zoom, I'm sorry. How do I reduce the screen so I can see Zoom?
Little line on the top. Click on that.
Nope, nothing at the top. Starting over.
Just let's see. Click on your blue camera icon for Zoom on the bottom, and you should see yourself. And then click on that. There you go.
I'm back.
Now put it in screen
I'm
show and you
Sorry about this. Thank you for bearing with me. So at this point, I would like to turn this over to my colleague, Dr. Annie Dondapati-Allen, to discuss what's happening with REST at the University Hospital. Annie?
Thanks, Jackie. So for this afternoon, my focus is going to be on the REST efforts here on the Anschutz campus. There are other sites within the UC Health system that are trying to stand up a REST team, but they're still in progress. So my focus is going to be on the efforts that we have here on the Anschutz campus. So REST is modeled after the program at Children's Hospital, and they were very kind to share their resources with us, but it has evolved significantly since its inception about 3 years ago. We had a pilot program that we did, and it was a great success, and then we launched it for the whole hospital. The REST program grew out of the CISM committee at UC Health that had been working very diligently for many years to develop a staff support response following critical incidents. And Reverend Julie Swaney was a crucial part of those early conversations and continues to support that the work that we're doing now. Next slide, please. So REST is made up of a team of folks that are from various disciplines. That includes chaplains, social workers, nurses. We have clinical nurse specialists, nurse educators, and employee health and wellness staff as well. And these facilitators have expertise in understanding the stressors that are very unique to the healthcare environment. And some of the tools that we've developed over the last 3 years are conducting debriefs, resilience rounds, and really working on some educational resources for staff resilience. And some of these are still ongoing efforts. So let's take a look at what a REST debrief entails and what's unique about it. So one of the most important things about a REST debrief is that or a REST submission, is that it encourages self-reporting of distressing events or extreme events. You may not be surprised to hear that there is significant underreporting of distressing events. Most of the staff are often surprised that they can, in fact, put a REST submission in when a patient or a family member is verbally aggressive, or if they've had multiple codes in a day. And so we really are trying to shift the culture and encourage the staff to self-report and to empower them to do that, and kind of teaching them that it's an important part of building resilience. REST is an emotional debrief process. It's not a clinical review. And we really try to create a safe space to process the emotional impact of the distressing events. And we provide education on staff resilience resources that are here at the hospital and throughout the system as well. And as I mentioned earlier, it's facilitated by our interprofessional staff and really focusing on building individual and collective resilience. As I mentioned, there are so many different opportunities for staff to request support through the REST program that we have here. REST is often one of the first tangible opportunities that staff have to experience an emotional debriefing process in the aftermath of a distressing event. And for many, it's the first time that they've even participated in a debrief. And often they're surprised at how helpful it is to talk through the event, to decompress, to process it with the team, or even if it's an individual debriefing itself. It's also often the first point of contact that staff have to understand and engage with the range of wellness resources that are present at the hospital and the system. As you can imagine, there are a lot of resources that are available on the website. Sometimes it's difficult to navigate, Very often when you're already distressed and you've experienced a distressing event or a critical event, trying to navigate through those resources can be challenging and overwhelming. And so rest is often that first point of contact to try and understand the resources that are there, and we help them to navigate to what is the most appropriate resource for them for that particular event. So let me talk a little bit about the rest process itself. It's a very simple 3-step process. So we have a rest form that they can submit, and it takes less than 60 seconds to do that. We want to know who the staff member is. We want to know what unit or the home unit is. And we ask them to tell us a little bit about the event itself. And it gives us an idea based on the narrative. We really pay attention to the description, the emotional impact that they're describing. Often it is just a couple of sentences. Sometimes it's quite elaborate. And within 24 hours of that submission, a rest facilitator will reach out to that individual or that team, and we then have a debrief process that is initiated. So when a rest lead reaches out to an individual, we try to debrief the event itself, and we really pay attention to how the staff member is doing. We want to identify the emotional impact and sometimes the physical impact of this particular event. There might be concern about whether they're eating, are they sleeping, are they having nightmares? Is it impacting how they show up at work, if they show up at work? And we really want to try to assess what their coping mechanisms are. Who's your support system? What do you need right now? What kind of support do you need in the days or the weeks ahead? And so we do that initial assessment. If a team debrief is requested, the rest team will collaborate with the unit leadership to schedule a debrief. And currently, because of COVID, of course, all of our debriefs are happening on Teams. And interestingly, we do have greater participation because of that. The staff that are not on shift are able to join from home, or if they're out for a run or playing with their pets or their children, they're able to join in that debrief. And the folks that are on shift are able to take a break and join as well. And the leadership on the unit is very, very supportive of that. In addition to processing the event itself, the triggering event itself, we are also very attentive to the themes that emerge, such as moral distress, compassion fatigue, burnout, secondary trauma that comes up. And these needs are then assessed in the course of the debrief, and we try to identify the staff that are needing any additional resources in the course of that unit debrief, and we direct them to those resources. One of the things that we've learned is that it's not very helpful to tell them, to find things on the website or to just direct them to the website. We always offer to help them navigate those resources. And if that means we need to set up another time with that individual staff member to do that, we do that over the phone or on Teams, or even meet with them in person and just show them all of the resources and just kind of support them through that process as well, so they know that they're not alone during that time. So let's talk a little bit about what do we do around the moral distress. So any of those discrete events that we just talked about can be a source of moral distress. The current state at the hospital and the system is that we do not have a formalized process to address moral distress when it comes up. In the course of rest debriefs, moral distress comes up quite often. And currently what we do is to identify it, name the moral distress, and then we try to provide some education about the resources. Currently, the only resource that we have is, we can direct them to some websites like Share to look at some resources there, but we really try to gauge if an ethics consult might be appropriate. And we find that very often that is a very helpful piece of information because staff have not thought about putting in a consult. And so we're able to do some education around that and even empower them to go ahead and put a consult in if that's a helpful next step for them. So during COVID, as you can imagine, things have escalated significantly in terms of moral distress, but just the kinds of needs that REST is seeing. So REST submissions still come in. We provide individual and team debriefs. In the course of this past year, starting back in March, we've added significantly to some of the resources that we're providing. And please bear in mind that all of these we had to stand up, we had to build these resources and stand up that response in real time while COVID was unfolding. So we have found great success with resilience rounds. We try to identify high stress units. We round on the units. We have informal conversations with staff. We do one-to-one support on the units as well. We did do decompression huddles at shift change for the morning and the night shift, and just the visibility on the unit, just asking staff as they're leaving from their shift, thanking them for the work that they've done, asking, if there's anything we can do to support them. If they're wanting to debrief very quickly, we did provide that. We also have collaborations with the Department of Psychiatry, and we have done over 100 team support sessions with the support of the Department of Psychiatry. And I can tell you that moral distress came up quite often during that time. Some of the things that we're doing now is continuing our collaboration with the Department of Psychiatry. We're doing some work around second victim trauma through our patient safety folks. We are adding VR goggles to our resilience efforts and behavioral health as well.
Thank you, Annie.
Hand off to Karen for
Children's.
the work
Thank
at Children's Hospital.
Karen.
Can you hear me? Great.
Yes.
Okay, so thanks. I'm going to talk about the debriefings that we have at Children's. We have both REST and moral distress rounds. So as Annie has so eloquently described, REST is an interprofessional forum. It is safe and confidential. The goal of REST is to focus on the team's emotional response to a situation. The difference between REST and moral distress becomes when in REST, we do not seek to fix anything. We don't look for solutions. Moral distress rounds, we actually get into solutions. At Children's, our REST is facilitated by members of our REST Council, who is mostly made up of our chaplains, social workers. There's a few RNs and a few physicians that are trained in the debriefing model. So as Jackie has talked about, moral distress is one feels this heightened moral responsibility. You have a sense of the right thing to do, but you're feeling impeded by fulfilling that ethical obligation due to those internal or external constraints. And it's these constraints that we want to talk about during moral distress rounds. It's directly related to the well-being of the patient. It's not a self-interest type of experience. We really want to improve patient care. It's accompanied by this perception of powerlessness, of helplessness, and sometimes feeling a victim. And it can definitely negatively affect our work if we don't address it. So moral distress rounds at Children's are facilitated by our ethics consult team. It's one of our tools. We can either offer an ethics consult or a moral distress rounds. It does differ from an ethics consult in that the consult is to assist the patients and the families and the team in addressing uncertainty or conflict around a value-laden issue. We want to provide an ethical framework for clinical decisions or treatment options, where moral distress is really more the concern and the barriers that are impeding patient care, either at the patient, the unit, or the system level. We want to develop strategies to protect and preserve our moral professional integrity. So an ethics consult is usually just very much the direct patient care team. not like moral distress rounds where we can cast a wide net and we can involve people in the entire unit. Sometimes it's the security officers or the unit secretaries who are feeling just as much distress as the bedside team. And it's very important to encourage them to attend. So in moral distress rounds, like a REST team, we want to provide a very safe interprofessional forum, but we're going to discuss the morally distressing aspects of patient care. Now we might talk about the feelings in the beginning, because there are feelings, there are emotions. There's anger, there's guilt, there's resentment, there's blame in when you first start experiencing moral distress, but we want to move away from all those feelings and move into some moral agency. We want to support and empower teams to raise these concerns and to name any of these conflicting values. Just by naming what the moral distress is can start to diminish the moral distress. We want to assist the staff in developing their strategies, right? In what is something that we could do at the patient level, at the system level, at the unit level. And these actions can also be a good response to decreasing moral distress. Moral distress is a catalyst for coming up with solutions to issues at the bedside. It doesn't always feel that way when we get into the room, but staff will find that when they're talking about what everybody's feeling, everybody has a different opinion, everybody has a different sense of what might be morally distressing in this particular case, but we're all coming at it with, we want to improve patient care, and we want to come up with ways in which we can do that. It gives us an agency, right? We have the ability to actually change something. We can maybe prevent moral distress in the future, or we can learn from it, and it's a catalyst to sort of help us not feel so overwhelmed and victimized by it. And we certainly walk away from a well-achieved moral distress rounds with a preserved professional integrity, because we have discussed as a team what is so distressful. We have listened to each other. We have listened to other views and other values, and we've sort of opened up our mind to what some possibilities are to improve patient care. So just to give you an example of moral distress, prior to COVID, some of the literature has documented that moral distress in hospitals specifically was related to prolonging the dying process with, aggressive treatment, or, providing potentially non-beneficial treatment. Those were the types of discussions that we would have in our moral distress rounds at Children's Hospital often. But once 2020 hit, these were sort of the themes that came up in our moral distress rounds. Some of these were very early on, preserving PPE. And by preserving PPE, this really got to the perspective of the team members who felt they weren't essential. They were wondering whether or not they should utilize PPE to go in and see a patient or a family when they weren't necessarily going to provide direct patient care. And so people like our social workers and our chaplains and our child life therapists were feeling like they weren't able to do what they meant and wanted to do for our patients because they needed to preserve PPE. And we had a child life moral distress rounds in which we were really able to problem solve through that. And how could they be very helpful in the room while doing a dual duty? Could they help the nurse while starting an IV and also being a child life therapist, and not, utilizing PPE that was essential? Obviously, we all felt that changes to the visitation was a very distressing thing. Not having family members there. Fortunately, at Children's, we believe that children need their parents, and so we did have a two-visitor rule for our patients, but that still was not what we were used to. We were often used to having, the family be able to come in, the siblings, friends. And end of life, we did extend end of life visitation at Children's. We would sometimes have upwards of 10 people in there, but it would take a lot of doing to get an exception. One of the things that was unique to Children's is we wondered whether or not we would take adult patients, and what would that look like, and do I have the skills to take care of adult patients? we all had to sort of change what we thought was best practice. And Jackie sort of mentioned this when we went from sort of a what's best for the patient in front of us to more of a universal. How are we thinking about, what's best patient care for everyone in Colorado, everyone in Denver, everyone at the Children's Hospital? That sort of moves us from what we consider to be the absolute best practice to a sense of, okay, we're going to do our best. It's going to be good enough. It's probably not ideal, but it's going to be good enough. But that movement took some work, and there was some moral distress in that movement. Obviously, we had some, worries about whether or not we would have enough beds and enough equipment. Would we need to move, ventilators from the NICU to, the PICU? Fortunately, we didn't have any of that happen, but that was in those early days, we had sort of that sense of we could be forced into those decisions. A big one for our team was sort of this duty to care between how do we take care of ourselves, how do we take care of our patients, and then still be able to protect our own families. We might have had, immunocompromised children of our own, and we are, caring for COVID patients in the hospital. And how do we protect our families? It was not an unusual experience for healthcare professionals across the country. We wanted to balance, our desire to help the areas that were surging. There was nurses who wanted to go to New York. Children's did let some nurses go to New York, but we couldn't let everybody who wanted to go to New York. Because we needed to make sure that we had enough patients, enough nurses here in case we had a surge. There was a sense of guilt at the Children's Hospital that we didn't have the same surge that our colleagues in the adult world had. We had a surge of a different kind. We had higher acuity. We had patients who might have come in sooner had it not been COVID, and so they were maybe a little sicker than we expected. But we certainly did not have the high volumes that we knew that our adult colleagues were having, and that was an interesting sort of guilt that we held. The health disparities became more and more apparent in COVID, and it continues. Certainly, there's never enough mental health beds for our pediatric patients, and that became apparent in COVID. If a mental health patient was COVID positive, it became really challenging to get them into placement, and our teams worked really hard. They were incredibly thoughtful and inventive in helping those patients have the best experience they could while they were waiting for beds. And now we've sort of moved into this anticipatory moral distress in that, what is this going to look like for children moving forward? They've missed some vaccinations, they've missed some well checks, they haven't been in school. We know that the teenagers are struggling because that it's so important to be with their peers. What is this going to look like? And how can we be active moral agents in recognizing early on if we have a situation, and maybe changing the way that we care for our patients moving forward, because we've experienced this pandemic as a community. So at Children's, we did 64 moral distress rounds in 13 different units. Obviously, some units had many, many moral distress rounds. The NICU had, I think, 11 or 12, and CCBD, our cancer unit, had 8, and our ED had 7. So some units will only call for 1 or 2 a year, and some units utilize this quite frequently. And not all of our moral distress rounds were related to COVID, but certainly almost all of our moral distress rounds had an element of COVID. It would come up in some way of just whether or not it was just sort of our own sense of this is really hard, that we're in the middle of a pandemic, to it's really affecting whether or not we can get this patient discharged. I think we managed to have 420 staff attend, and they, as you can see, it's of all different interdisciplinary members, the physicians, PAs, NMPs, along with our nurses, social workers, chaplains. It's great to have a multidisciplinary group in the room. Prior to COVID, we did not allow people to call in, and we certainly did not have any virtuals set up. So we usually averaged about 4 to 6 in a room, which I felt was fine, right? If I can help 4 to 6 team members feel better, problem solve what might be some solutions to what is so morally distressing about a certain case, I felt like that was a good group of people. But COVID allowed us to think differently about these rounds. And we opened it up to both Zoom and Teams, depending on what the unit wanted to use. And it just grew. Like Annie said, it's just exponentially. People loved being able to join virtually. And the worry when we didn't have virtual or call in was that people would be distraught and we wouldn't be able to really meet their needs, that somehow they would hang up and we wouldn't know how distraught they were. But we haven't found that. We have found that people stay on the line, and they tell us that they've really been, felt like it was a really positive thing to be able to Zoom in from home, maybe have their kids in the other room, have their headphones on, so it was still confidential, but to be able to hear what others were hearing. I would often come in at 5 in the morning and do a night shift, and then maybe do a 4 o'clock for the day shift. But by having Zoom or Teams, I'm able to have those teams, both of them together. So the night shift is hearing what the day shift is thinking, and vice versa. And that's been hugely helpful. So it has been noted as a magnet exemplar. We had our 4th redesignation at Children's this August, and the ethics committee was noted for offering this and really supporting nurses at the bedside to address ethical issues. And one of the biggest supports is the moral distress rounds. So for the nursing leaders who are listening, it really is valuable for your nurses, and it is noted by Magnet. Thank you.
So much, Karen.
Thank you all. We really appreciate it.
Julie, one more important slide, please.
Okay.
Let me get my face back. So what are we doing here at the U? Megan Prescott and Kristen Ferfari are developing a program. It's now in its pilot phase. They're going to build competencies around moral distress at the individual and team unit levels. It's innovative, creative approach to building a moral resilience program. And we're excited to learn more about how ethics teams can use our unique training and perspective to target this complicated aspect of patient care. We look forward to expanding the program with what we learned from this pilot. So here's a couple resources. The share resource, don't miss the share resource. Dr. Gray is an illustrator, and he has wonderful illustrations in palliative care. And here's Wendy Dean's Fixed Moral Injury. And here are the resources from our presentation. Thank you, Julie. Now.
Okay. Fantastic. Thank you all. Really a lot of good information. There have been quite a few requests for copies of the slides, or the recording of this is going to be posted, I believe, tomorrow, according to David, so you can access that. Also, there is all of the slides, and then there is the link to the share site, the URL that has all of the resources. I've actually looked at that as well, and prior to this, and it really is excellent. So good job, Jackie and Karen and others who put that together. It's really a great resource. So watch for the recording tomorrow. There are a couple of questions that have to do with disparities. And in particular, questions about, do your moral distress interventions, if or how do they take social determinants of health and health care into consideration? A few of you a little bit touched on that, but could you say more about how that is fitting into moral distress rounds?
That's probably a question for me. And I guess I would need a little clarity in what they're asking. Are they asking if that's part of the moral distress that staff feel? Certainly, right? Health disparities is definitely a piece of the moral distress. Now, there's times in which we can, at the patient unit system level, in which we can help those disparities. That may in fact be some of the problem solving that we do. And so then that might, meet those needs. It obviously, we can't always meet the needs of the health disparities, but in the hospital, we certainly can try and offer people, the same as anybody else. I don't know that that answers the question for the
Annie?
person who asked that.
Annie, can you?
Sure.
This is
So
Don Parsons.
Go
I asked the question.
Don, you're muted.
I was trying to get on the video, but I can't do
Okay.
it. An example might be a patient is well enough to leave the hospital, but does not have a safe place to go. And there is a demand for the bed. Well, that creates a terrific sense of stress, I would think, for the nurses, doctors, and others. But there may be many other similar examples. So it may be that an individual provider herself or himself has serious problems at home with, who knows, financial issues or childcare issues or domestic violence, relationship issues. Do you take those issues into consideration when you do your consulting?
Annie, can you speak to it? A safe enough
Sure.
discharge is one of the most frequent ethics consults. I will say that. And Annie, can you speak
Yes.
to other aspects?
Sure. We during rest debriefs, if it's a team debrief, my experience has been that there is some hesitation on the part of staff to talk about it in a larger group. But in one-to-one conversations, they are able to name that, their concerns around it, maybe, really tap into some of the anger, some of the distress that they have, and just having that safe space to process one-to-one in a safe, confidential manner is really helpful for them. So it does come up, but I think they feel safer in a one-to-one conversation than they do in a larger group.
But you're right, Don, in the sense that, and others of you commented on this, that disparities have been front and center, and have raised huge systemic issues well beyond the hospital system. And that is a source of distress, I believe, for lots of people. And some people are finding some empowerment within that to address it. There is another question, though, that is somewhat related. It's great that you're including systemic issues. How are these concerns raised to the greater system, and how does it respond?
That's you, Karen.
Yep. So if during moral distress rounds, I learn about things that might be either at the unit level, I can speak to the nursing manager or to the medical director. And if it's at the system level, then I will take it up to senior leaders. They are open to hearing concerns. And in fact, we had a moral distress rounds this summer in which we had the chief medical officer join. Heather and I had one moral distress rounds, and we realized that if we brought the chief medical officer to the moral distress rounds, he could hear firsthand what the team was feeling. And the children's senior leaders are very open to hearing what the staff have to say, and then taking that and seeing what they can do.
Thank you. This is a question that has to do with neurobiology and morality. Can you speak to the connection between the work that Dr. Darcia Narvaez does with interpersonal neurobiology and morality? How can we help heal one another and teach these healing mechanisms to one another at various stages of development? Is anyone able to address that?
Not really, but I am not a philosopher, not a neurobiologist, but I do acknowledge the brain in our judgment and all the good work of moral psychologists I loved reading Behave and learning about all the body and how you make judgments. I will say this, I think it's an internal practice. I'm reading a book talking about traumatized, a racial trauma. And this is a trauma specialist that's working with people of all different races and police forces around how are you triggered and how can you rest and not trigger yourself. And so there's a word out there about yourself. And I think being an Aristotelian, I think it's the community makes a big difference in discussions about making it safe to have discussions, helping having an ethical climate where people are expected and allowed and encouraged to grow and develop. So it's both and. I know there's science behind it, but also there's a lot of good references to help individuals settle and hear and grow, and help communities do the same thing, settle, be able to raise issues, settle and grow together. I know that's not an answer. Thank you for it. Can you put in the chat that reference? I would appreciate that reference.
Great, thank you, Jackie. One last, it's a comment, and maybe Annie, you could respond to this if you're able. Joan Halifax has some great work on over-empathic arousal, which would support the REST model in being more attractive to leadership and management, because it speaks to the efficiency that is lost when individuals are over-empathically aroused. That's a comment.
That's
but,
a great, yes.
Yeah.
Yes. And I think debriefs could be an opportunity to really address that. I think especially during COVID, there isn't a break between our work life and our home life. We're thinking about COVID all the time. And so that over-empathic response, where during normal times might have been more manageable, might be tested a lot more. And I wonder if a debrief or one-to-one check-ins are opportunities to kind of begin to identify it, if nothing else, and see how you can manage that a little bit better.
Wonderful. Thank you. I'm aware of time. I really want to thank you not only for this presentation, but really for the work that you've been doing. I know that this has been a lot organizationally, and it has been so essential in getting everybody, particularly through this past year. But really appreciate your presentation, your clarity with such a complex topic. So thank you, and we'll look forward to hearing how this continues to evolve. Thank you, all of you, for your questions and your comments. And also wanted to again remind you that Ethics Grand Rounds will be next month, will be February 11th at noon. And it will be Dr. Mark Ernest from our Department of Medicine who's going to be speaking on health policy. I don't yet have a title for that, but it will be on health policy. And we look forward to that. So hope you can join us for that time. And again, thank you very, very much, Karen and Jackie and Annie. Very much appreciated, and nice job.
Thank you.